Hello, enjoy this lecture on rapid sequence induction. It is like never before. If you enjoy it, make sure you share it. I'm sure you will enjoy it. Bye. Hello, good morning, good afternoon, good evening, depending on when and where you are watching this video from. Welcome to Anesthesia and Intensive Care Made Easy. This is Dr. Kate. There's something in the classroom today. Welcome to classroom. Today we'll be discussing a very important topic, rapid sequence induction. Are you a resident in anesthesia? Are you a resident in ICU? Are you involved in emergency intubation of a patient? Or you're getting ready for exams, or you are preparing for exam? Because this topic is also an exam question. So come, there's something for us to learn. Rapid sequence induction is the topic for today. Made easy, I said. Rapid sequence induction, from that name, there's induction, isn't it? Meaning it is a form of induction. So why did you need this form of induction? It's for airway management, to prevent aspiration, isn't it? So look at introduction. Rapid sequence induction is a form of induction and airway management in anesthesia. Of course, it's in anesthesia, isn't it? That is indicated when your patient is at risk of gastric regurgitation and pulmonary aspiration. Patient is at risk of gastric regurgitation and pulmonary aspiration. It is aimed at promptly taking over the airway to prevent aspiration and the morbidity and mortality that is aspirated with pulmonary aspiration. That's the aim. The aim is to quickly take over the airway. And it was described using these two drugs, susamethonium and sodium thiopental, for the reason of their quick onset of action. And its duration of action is about 5 minutes or a little above 5 minutes. That duration of action of susamethonium. Within a minute, onset of action of susamethonium has started. While sodium thiopental is able to induce hypnosis following 1 to 2 ham-brain circulation time. When you hear ham-brain, you know you set IV lines here in the theater. As I tell you, you are giving sodium thiopental. When it goes to the heart, 1 ham-brain circulation time. You go to the ham, to the heart, and then to the brain. Immediately it gets to that brain, once, twice, the person is already sleeping. So it's able to induce hypnosis at that short time. And that is why they use the two drugs to describe rapid sequence or to demonstrate rapid sequence induction. So anytime you are using outside these two drugs, because of the clinical condition of your patient, then it is called modified rapid sequence induction. For example, sodium thiopental will cause hypotension as one of its side effects. And if you have an hemorrhaging patient, or a patient in shock, or a patient that is bleeding, a woman with placenta previa, abruption placenta, coming for surgery, emergency surgery, you know that sodium thiopental is going to drop the blood pressure. You may want to use ketamine for this woman and still use the susamethonium. Because you are not using sodium thiopental that is used to describe rapid sequence induction, it is now referred to as modified rapid sequence induction. It's also possible that you don't want to use susamethonium. For example, a patient that is spinal cord injured, greater than a month, has been bedridden for 1 month, and is coming for example, any surgery. Is it spine fixation? Is it debridement? Or for whatever reason is coming to the theater. When you use susamethonium for anesthesia, for that kind of patient, for muscle paralysis, for endotracheal intubation, it is going to put the patient at risk of hyperkalemia. This is because of the proliferation of acetylcholineceptors, acetylcholine receptors. They also refer to as acetylcholineceptors. Because of the proliferation of this acetylcholine, because of the paralysis, which is the pathology from spinal cord injury, you know, the acetylcholine were proliferating, thinking they can restore the muscular function or the function at these limbs or the extremity. So because of this proliferation, when there is depolarization of these multiple or numerous acetylcholineceptors, there will now be release of potassium. So it will put the patient at risk of hyperkalemia. And you know the problems associated with hyperkalemia. Of course, hyperkalemia is going to stop the heart, will be at risk of cardiac arrest. So if, for example, you have an emergency procedure to perform in a patient with polio, patient that have chronic illness that have been bedridden, or a patient you suspect will have acetylcholine receptors proliferated everywhere, and you don't want to use SUSA because SUSA will predispose the patient to, or not patient, predispose the patient to hyperkalemia. Then you want to use drugs like rocuronium and other short-acting drugs. You want to try to see what else you can do. That is referred to as a modified rapid sequence induction. Or you want to pass NG tube to empty the gastrum, before you intubate, so that the risk of regurgitation will be reduced. Because when regurgitation is reduced, aspiration will also be reduced. It's also modified rapid sequence induction. Talking about rapid sequence induction, which class of patient is at risk of gastric regurgitation or pulmonary aspiration? Because you need to be able to select your patient before you continue or you now start up the process of rapid sequence induction. Any full stomach patient, any patient that is full stomach, any patient that is at risk or has a pathology that has predisposed the patient to increase intra-abdominal pressure, and that will transmit to increase intragastric pressure. Okay, so anything that will increase the pressure in the gastrum, in the abdomen, will put your patient at risk of regurgitation and subsequently pulmonary aspiration. So we class them. One, who are the full stomach patient? Pregnant woman, for two reasons. One, because of the weight of the baby in the womb, okay, and the womb in the abdomen will increase intra-abdominal pressure, and this will transmit to intragastric pressure, especially when it's close to term at the third trimester. This can also be splitting the diaphragm and then increasing the intragastric pressure. And I said for two reasons. The other one is hormones. Hormones that are related or that are there at pregnancy, they have effect on the gastroesophageal sphincter. The gastroesophageal sphincter, I know you know as a doctor, they are that junction between the esophagus and the stomach. The tone actually prevents regurgitation and prevents vomiting. So the effect of hormones on this sphincter will cause it to lose its tone, its strength, and then its last. So the pregnant woman is at risk of regurgitation. That's why they have dyspepsia. When the stomach contents begin to come up to the esophagus, acid, the epithelium at the esophagus is different from the epithelium in the gastrum. The one in the gastrum is used to acid, isn't it? But the one in the esophagus is not used to acid. That is why they have dyspepsia. They have hard bones when this acid begin to come to the esophagus. Two reasons why pregnant woman is full stomach. Then emergency. Anyone that is an emergency patient is termed full stomach for two reasons too. One, if they are rushing one who had ROTA, road traffic accident, for emergency surgery, emergency procedure, you can't tell, maybe unconscious or drowsy or not oriented in time, place, and person, depending on what condition you are seeing the patient. They cannot tell when they took the last meal. And you might not have time for a good history. And you might not even get the history of the last meal. You see three things. They will not be able to tell you the time if they are unconscious, the time they took the last meal. You might not be able to get the history of the last meal. You are in a hurry and they cannot even talk, or they are unconscious. And you might not be able to even get family history of whatever it is that they have. For example, diabetics are at risk of they are termed full stomach because of neuropathy that's associated with diabetes mellitus. So for those reasons, that's one. And then there's what they refer to as stress hormones. Imagining, for example, following ROTA, they are rushing people into the hospital for emergency surgery. At that time, they had trauma. The hormones that are released, the cortisol, the adrenaline, noradrenaline, okay? These hormones are counter-insulin. The cortisol, they delay gastric emptying time. Stress hormones delay gastric emptying time. So even if your patient is telling you that the last time she took me was 8 a.m. in the morning and she now had accident by 9 a.m. and then they are rushing her to the hospital by 12, maybe the distance from the hospital by 12 or by 1 p.m., 12 noon, and she will now say, no, it's in the morning I ate, it's still full stomach. This is because the stress hormones that were released as a result of the ROTA, they have delayed gastric emptying. They are not allowing the food that we're eating there to go down their full stomach. And anything that will increase intra-abdominal pressure will include intestinal obstruction. Any intestinal obstruction is full stomach. Intra-abdominal tumor, intra-abdominal malignancies, constipation, anything like I told you, ascites that will increase intra-abdominal pressure will translate to intragastric pressure and put your patient at risk of regurgitation and aspiration. You must also know too that some neurological problems will also
be a reason why a patient is called full stomach. For example, gastroparesis is seen with diabetics, so they are full stomach patients. So I have identified patients who are full stomach. All right, and you get this information from the history. From the quick history, you have some of this information, and from examination, you can also find out this information and know that your patient is full stomach. Having selected a full stomach patient, they will now come to the art of rapid sequence induction. You must know that rapid sequence induction, you need 2 assistants, which is a requirement. Requirement for rapid sequence induction will be 2 assistants, including you, that is the anesthetist. The assistant, one of them is trained on giving Selix maneuver. Selix maneuver is also referred to as cricod pressure. It is after the name Selix Otto Brown who discovered that pressure, that Selix maneuver, or that cricod pressure will help in preventing regurgitation. So they named it after him. So one of your partner, one of your assistants should be trained on applying or giving cricod pressure, while the other one will be the circulator, is the one that will give drugs and attend to the other things. That we're talking about requirements. 2, you require a high volume suction. There's a difference between high volume and high pressure suction. I'll tell you today. And don't forget, don't just say suction, you must say high volume suction. Have you seen a Yankers before? The mouth of a Yankers is small, so it takes secretions. But for example, there is granite, there is a in that secretions. The Yankers with a tiny mouth will not be able to suction it. That is referred to as high pressure suction. When you talk about high volume suction, these are suction that has wide nozzle, wide mouth. It can be the body of the suction itself. Why? When you put it in whatever secretion, whether it's a bar, whether it's granite, it will be able to suction it. This is because a patient that is coming for emergency, that you are going to have rapid sequence induction in order to prevent regurgitation and aspiration, might just have eaten a bar, might just have eaten granite. So full stomach can be anything there. So if you use Yankers with a small mouth, which is high pressure suction, it will only suction the secretions and leave the bar and granite and every other thing behind. So but when it is a wide bore cannula, wide bore suction nozzle, wide bore suction nozzle is referred to as high volume suction. It can suction the air, it can suction the rice, it can suction the grains of the airway. That's the suction that is needed. Another thing that is needed is a teatable bed. You can't just choose any theater bed for your patient. The bed must be teatable. Why? In trying to prevent aspiration, regurgitation and aspiration, your patient might still regurgitate. Yes, you can't say never. So if, for example, your patient regurgitates, your bed should be one you can quickly give a hair down. You quickly tilt down your bed so that whatever is being regurgitated cannot go into the airway. So you take down the head of the bed, you section the oral cavity, and then give oxygen. So your bed must be a teatable bed. And then you must have, of course, when you're preparing for surgery, you must have oxygen. But what is important is that you must pre-oxygenate, and you must be seen to talk about pre-oxygenation, because this is the only time you have to oxygenate your patient before endotracheal intubation. After you have started induction of anesthesia, you no longer pre-oxygenate in rapid sequence induction, because your pre-oxygenation will send gas to the stomach. You know that when you are max ventilating, you are ventilating both the airway and the esophagus, because you have not intubated. The patient is no longer awake, your patient is sleeping. So the cuts are no longer controlling to ensure that air goes to the airway and not the stomach. So as at the time you are ventilating a patient that you have induced and paralyzed, it will increase intragastric pressure because you are sending air into the stomach, and therefore puts your patient at further risk of regurgitation. You pre-oxygenate before the induction of anesthesia. Another thing you need to know is rapid sequence induction. So the drug is given in rapid succession. You don't titrate like you titrate in fasted patients. So for that reason, your drugs are drawn and labeled and kept on the table. Drugs drawn and labeled. Calculated doses, drawn and labeled, because you don't titrate in rapid sequence induction. Another thing you have to do, you must cancel your patients. And why do you have to cancel your patient? Because cricod pressure is applied at the onset, as the beginning of induction, and at that time your patient is still awake. Although the pressure that is given at the onset of induction is different from when your patient is now asleep. We'll talk about it. So you must counsel your patient that as at the time you are about to sleep, there is going to be press on your throat. Somebody is going to press your throat. Please don't be startled, don't be afraid. Okay, we are trying to help you. It is done so that whatever is in your stomach will not go to the airway and cause you problem. So just tolerate it. It is the doctor that is doing it. So you must counsel your patient before rapid sequence induction, before you commence induction. So coming to induction of anesthesia. Before the induction of anesthesia, the assistant that is trained on applying cricot pressure must commence. But before your patient fall asleep, a force of about 10 Newton should be applied. 10 Newton. And when your patient is not asleep, you can get as much as 30 Newton. And it has been seen that every cricot pressure above 40 Newton was seen to make endotracheal intubation difficult, because it will distort the anatomy of the airway. So there's no need actually pressing so hard until you distort the anatomy and now make endotracheal intubation difficult. There are some factors I need you to know about the cricot pressure. The cricot pressure is actually applied at the cricot cartilage. And this is because that is the only complete ring of the laryngeal cartilage. It's a sinnet ring. That's how they describe it. So what it means is that that complete cartilage is like a ring like this. So if you press it, it will not collapse because it's ring-like. Instead, it will transmit the pressure with which you used to press it to whatever structure that is behind it. And which structure is behind it? The esophagus. So when you press the cricoid, when you press it at that level and press the only complete ring, it transmits the pressure and occludes the esophagus. And it presses it against the body of the sixth cervical bone. So at the body of the sixth cervical bone, the esophagus is locked up and they're preventing a regurgitation. If there's no regurgitation, there's not going to be aspiration. That's what the cricot pressure will do. So as at the time you start up the cricot pressure at the onset of induction, the induction is commenced immediately. Immediately after induction, the muscle relaxation, that's the Sousa methodium, is given. And the airway is quickly intubated, confirmed, and secured. And then connected to the mechanical ventilator or the British circuit, which connects the patient to the mechanical ventilator. So common questions that they will ask. So if you talk about the process, okay, you must talk about first the introduction, you talk about the aim, in case you are writing an exam, you talk about the aim, and you talk about the requirements, where you talk about personnel, and you talk about the equipment, and then you now talk about the acts, the process of rapid sequence induction. They talk about the counseling, and don't forget that you must do a pre-machine check, pre-operative machine check. But because these are not points in rapid sequence induction, but you can just put a point. Don't talk about the things you'll be checking because it will kill your time. Just talk about pre-operative and anesthetic machine check. Just leave it as small points because that's not what is needed here. And then you now come up to your drugs drawn and labeled, because you don't give drugs in aliquots. You give it in rapid succession. Calculated drugs, calculated dose, given in rapid succession. So common question they will ask you when you are trying to intubate your patient, where cricot pressure is applied, and unfortunately your patient starts regurgitating, what will you do? Do you have to apply harder the cricot pressure, or you relieve your hand for the patient to regurgitate? What will you say? The answer is immediately, if you are applying a cricot pressure and your patient still seems to be regurgitating, you remove your hand to relieve the regurgitation. You tilt down the head of the bed so that whatsoever is being regurgitated will not go to the airway. When you tilt down the head of the bed, then you not use a wide nozzle. That's why I told you a wide volume suction. Okay, wide. The suction nozzle should be wide so that it can take whatever particle that is in the regurgitation. Then you tip the bed and quickly suction the airway. Don't waste time in doing that because you need to oxygenate your patient. You suction the airway and then give oxygen to your patient and start up the process again. Okay? So if you don't relieve your hand, you know what will happen? Because there's a pressure with which the food or whatever is in the stomach is being regurgitated or is being vomited, whatever it is. If you don't relieve your hand, it will cause esophageal tear. And once there is esophageal tear, gastric content will not leak into the mediastinum. It can cause mediastinitis. It can even result in a situation where you have to do a thoracotomy with esophageal repair for your patient. And you will see that your patient that actually came in for one pathology will now go back with a worse pathology, where you now begin to do thoracotomy and esophageal repair. So you must remove your hand, and you must tilt your bed like I told you and suction the airway. Which other question that they will ask? The other question is the fact that pre-oxygenation is important. They can ask you, why is pre-oxygenation important? You will let them know that you do not have another opportunity to pre-oxygenate until patient is intubated. Unlike, for example, if you have a fasted patient on table, when you are pre-oxygenating, you can be pre-oxygenating and be giving drugs because you have the time. Even while the patient is under anesthesia, you can still be pre-oxygenating. But you don't do that with rapid sequence induction because the pre-oxygenation will increase intragastric pressure and put your patient at risk of regurgitation and pulmonary aspiration. So rapid sequence induction, I haven't talked about this process. Then you will talk about rapid sequence summary. Rapid sequence induction, which is a form of airway management and induction in anesthesia, is actually aimed at preventing the morbidity and mortality that are associated with gastric regurgitation and pulmonary aspiration seen in full stomach patients coming for emergency surgical procedure. That's it with rapid sequence induction. That's just it. What are those special things you need to know? After this lecture, we're going to be talking about aspiration pneumonitis. So that is it with rapid sequence induction. So simple. It's not difficult. If you can't get it at once, go over the video again. You will like it. Have a great day. Hope you have learned something. That's why your teacher is always here. Anesthesia and intensive care made easy. Share it with a doctor. Share it with a colleague. Never a dull moment here. Bye. Have a nice day.